drug me out of the field, so I got to take a shower and clean up for a little while. So I appreciate you calling me and asking me to do this. It's always good to be in front of this crowd. This is a familiar face and business leaders in our community, so I'm always excited to be part of that. Today we had an opportunity to have a really special speaker, and I'm glad that when Ethan and David called today, we're going to have Ralph come over and speak about some issues that he has expertise in. I thought it was a great idea because in Frankfurt, just like I work at a bank and construction industry and farming, in everything that we do, we rely on people that have an expertise and a background and a working knowledge of what's going on. And that's what makes, in the Senate, really a neat opportunity because everybody brings something different to the table. And Ralph, when he was able to win that seat and come in, he really brought a huge understanding of the medical industry and medical field to our caucus. And we've relied on him heavily. If you don't believe it, just look at his bill log on how many bills he files a year. You'll find out how much we rely on him. We all give him a hard time because he files probably as many or more bills than anybody. And it's not that he wants to or he has a desire that he's led to do that. It's because there's so many things that need to be improved in the medical industry that his expertise and working knowledge can really help us improve that. Because this is one of our biggest expenses in the state is our Medicaid costs and Medicare costs and all of our healthcare issues. And so Ralph has been a great friend. We communicate on a really often basis when we have issues that are pertaining to our expertise and our knowledge. And I've enjoyed his friendship, and I think he's going to be able to deliver some really great remarks today. I'm glad to see that he was on campus today. We were able to showcase what Eastern is really known for, and that's their nursing program. And so the things that we do in helping people become career ready. And so I'm glad he was able to be part of that. And his bio was really, really large, and so I lose interest before I could read all of it. So, I'll leave this for you all to read. He's done a great job for us, and we're really pleased to have Ralph. I've been serving with him now 4 years, and so I've been there 8. It's been a great experience. So Ralph, we look forward to hearing your testimony. And your testimony, I think I'm in Frankfurt. I'm sorry. It may be testimony. I'll listen, but your remarks, and we appreciate you being here. Senator Alavarado.
Good afternoon. This is a great crowd. I'm glad everybody came out today, and I want to thank Ethan really for the invitation. I want to thank Dave as well for showing me around today to the campus. You've got Angie Wood, who's a nurse practitioner who worked with me for years in my office, has gotten her doctorate in nursing as a professor here, and so it was great to see a familiar face, and really a stellar program. I know the folks that are teaching some of those students and tremendous simulation labs and things, and a massive shortage that we have in nursing. So looking forward to EKU having a say in helping us fill those needs. Also, Louis Diaz, good friend, I got to know when we went on a trip to Notre Dame like a couple of years ago, I guess now, and drove back in the middle of the night. He gave me a lot of education also on housing tax credits and things that are important. So it's been great to get to know him and other members of the board here, which I'm proud to consider friends. So thank you for the invitation. When you get an opportunity to come and talk to a group as a legislator, you get kind of into your legislative mode. And so I was asking a little bit about what you wanted to hear about. And they said healthcare. It's almost more dangerous for a doctor to kind of tell you the things that are wrong with healthcare, things we need to get fixed. And so I'm going to try to be as good as I can on some of this. And I'd like to have an opportunity for Q&A because sometimes people will have questions of things they've heard about or they're curious about, and they'd like to see answered. And so if you have any of those, please be thinking about those. And I try to provide as much information as I can. This past session, as I'm sure Jared could probably confirm, it's been one of our nastier sessions we've had up in Frankfurt. I try to remind people there were 890 bills filed, about 170 of those that got passed. It's really impossible to cover everything, but the good news is that from the actions we've taken in the last couple of years, Kentucky's future is very bright. I think we've got, in the last 18 months, over $14 billion of investment into the state, of new investment. We've got, I think, 20,000 new jobs that have been created in the state in the last 2 years, with the lowest unemployment in 2 generations, which is tremendous. And so things are looking good. And I think our neighboring states realize that suddenly we've been shattering records that we've never achieved. And I think they liked it better when we weren't competing for a lot of those jobs. And so that we're actually starting to get on the map of a lot of manufacturers who are noticing what Kentucky is doing and the advances we've made. And I'm pretty excited about being part of that. The big 4 bills I think everybody's heard about, obviously the pension bill, there's the revenue bill, the budget bill, and then the phase-in bill. And I'm not going to go into detail on all of those. I think a lot of us, and probably as members of the chamber, you've heard a lot of the details about those things. Some of them are being challenged in the courts now. I think that those bills we passed forward put Kentucky in a lot better place moving forward. As far as I tell people, it's often like taking, for those of you who are in the banking industry, to go from an adjustable rate mortgage, basically, that you don't know what the cap on your rate's going to be every year. We switch it to a 30-year fix, a little higher payment, but we know what we're going to be paid off in 30 years. I think we're going to look good moving forward. So hopefully all those will be found to be legal and kind of meet their day in court and hopefully get passed and we can get those things done. As to healthcare in Kentucky, there's a lot of topics. I was preparing some notes for the talk today, trying to be as concise as I can. And I probably need an entire day to go through all the intricacies of what's going on. I tell people healthcare is like a spider web. You got a lot of strands attached in different locations. A lot of them cross with each other. You touch one part of that web, the whole thing shakes. And so if you think you're adjusting one little thing in pharmaceuticals, you'll have somebody in a clinical setting somewhere in a hospital saying, hey, that's affecting me here or there. And you have to sometimes know where the pressure points are to be able to get good policy done because it can be very tricky. Unfortunately, I've had a lot of experience in a lot of different aspects of healthcare, both as a clinician. I've done administrative work in hospitals. I've had an opportunity to do work with insurance companies, being medical directors for those sorts of things. I've worked in long-term care. So I know patient needs, pharmaceutical needs, doctor needs, hospital needs, all those sorts of things. There's a lot of issues right now in modern-day healthcare. Physician and nursing burnout is one thing I think if you're not a provider, you may not hear much about. But with all the regulations that have come down from the federal government, from the state government, people often look at our providers as robots. You just plug in a doctor and they go. You don't think about them having personal lives and families, and they never get sick, and they're not supposed to get sick. They should never have vacation. I know as a doctor, when I've taken care of people, when I took a week off, when I came back, the patients were mad. Where were you? Oh, when I was with my family. Well, what am I supposed to do when you're, and you have someone covering for you, but it is hard to develop that personal relationship. A lot of our providers are burning out. People are retiring earlier, and they're looking at other fields of business. I've had a couple of colleagues, one who's doing carpentry work, another one who became a trucker and abandoned medicine altogether just because they don't want the pressures of the job before them. There's a lack of providers, partly from that, but also because we have greater needs in society. We've seen a lot of the issues of mental health needs that we have in Kentucky now. We don't have enough providers. I think we have about 1 million children in the state of Kentucky, and only 59 child psychiatrists total for those 1 million children. Half of those take self-pay only, they don't take insurance, and most of them are either in Lexington or Louisville. So tremendous needs and a lack of availability for healthcare providers. We have rising costs of Medicaid, rising costs of long-term care, so access to healthcare becomes an issue and a concern. And we've also got a lot of our managed care organizations. That's a new partner ever since we've expanded Medicaid. We've introduced them into Medicaid, help us manage healthcare costs. And it seems like a lot of the bills that we file anymore are often to help get our MCOs under better control and to make sure that they're doing things the right way. So that's become another factor. We have a lot of bureaucracy. If you go to your doctor regularly, you're probably going to notice that they probably have a computer system now, something that wasn't present 15 to 20 years ago. And they spend a lot more time probably looking at that computer screen than they do looking at you. I know as a doctor I find that very frustrating. But your payments often become based on what you're putting in that computer screen more than what if you're diagnosing something right or wrong. And so that little pen that they put on the computer screen, what they put in, those boxes they check, becomes almost more important for some providers, unfortunately, than the care. And that becomes part of that burnout factor. Liability climate, a huge issue. I think we have the second highest per capita lawsuit rate for nursing homes in the country, behind Florida. I think it costs us to take care of a nursing home patient in this state 7 times more than it costs in Indiana. A lot of it from liability costs. I have several nursing homes I go to, one in particular in Winchester that I go to. Their malpractice liability insurance policy is $1.6 million annually with a $500,000 deductible as part of that for 140 patients. You can do the math and see. I mean, they struggle. They can't even break even most of the time. And there's countless stories I've had of nursing homes with high ratings and quality that just can't keep up because of the liability costs. We're losing a lot of long-term care providers. I know extended care has left the state. Referred care is another nursing home chain that's left the state. And pretty soon, people aren't going to realize when you lose a nursing home, it's a big provider of employment, but also for folks in your family or people in your community that have those needs, they have nowhere else to go sometimes. And that's the last resort. If you start to lose those over liability issues, it becomes a concern. There's one hospital in particular in eastern Kentucky that has been told by their malpractice carrier that they're going to probably drop them. There's no amount of money they can charge them to help cover the liability costs due to the number of lawsuits they've received. and there's no one else willing to insure them. So you have major regional hospitals now looking at the reality of not even having a malpractice insurance policy or having anyone who's willing to insure them, and they may shut down as a result of that. We were able to pass kind of an important bill, medical review panels, that we got done a couple of years ago as an attempt to help thwart some of this, to get rid of some of the frivolous lawsuits. And that's going to be before the Supreme Court in August for a hearing to determine. Obviously, the trial attorneys didn't like it. They've had a proxy file a lawsuit, and we're seeing if that's going to survive constitutional muster or not. But I'll talk about that a little bit later on as well. Opioids, narcotics are obviously a big issue also for our entire country, for that matter. But in Kentucky, it's particularly bad. Some recent stats that have come out recently talking about the number of deaths that we have and where we rank as a state and the rest of the country. As a legislature, we passed things like Narcan dosing, and the hard part we have now is that we've got first responders who can give Narcan, but they've got repeat customers. People, if they go and administer a Narcan dose, they wake up, they're upset that they've had their high ruined. They'll overdose again that evening, only to have our paramedics show back up, give another dose of Narcan, and go over and over again. And so how do we handle that issue, where you can have society wants that person to get better, but that person themselves may not know that they have a problem or unwilling to do what they need to do to get better themselves. So it's a difficult thing between forcing someone into rehab or not. Pharmacy costs obviously is a big issue as well. We've had some recent bills we passed in that regard, but there's a huge issue with pharmacy benefit managers, how do we control costs, manufacturers, people buying the generic medicine just to take it out of the market so that their branded drug will be the only one on the market that people will have to use. And we've seen a lot of those stories on a nationwide scale as well. Transparency of overall costs. I think people often don't know how much something costs. If you could go into a hospital and someone actually tell us, hey, what's it going to cost me to have a surgery, go through the whole process, we're often left in the dark. We don't really know a lot of those issues. Insurance companies don't tell us who's in network, out of network, a lot of those struggles that we're starting to see. And then obviously our statistics in healthcare, which is obviously one of the bigger concerns. We've got people that are in public health here today who obviously it's very important for them in terms of prevention, but I think we're second worst when it comes to exercise as a country. We've got huge obesity issues. I think we're in the top 5 worst for obesity. We have the second worst adult tobacco abuse in the country. We have the highest youth smoking rate in the country. The youth smoking rate is higher than the national adult smoking rate at this point. Some of the highest cancer death rates as well. I think we still are highest in cancer death rates. We've made some strides on colon cancer screenings. We've had some bills we've passed, and I think we went from 49th to 17th, I think, in overall screenings. So we've done really, really well. Central part of the state, western part of the state, achieving really high rankings, but we still have work to do in southeastern and eastern Kentucky. So with all those things, I try to get a list of these. There's a lot of the issues that we've got before us, and there's lots of ramifications of all that. When we start talking about an overall view of what healthcare is, those are some of the things we've got to work on. And when I start thinking about how do I get some of these things fixed in the state, that's where all the bills that I file come from, as far as trying to get different aspects of that kind of fixed. The federal government has given us some encouraging signs here in the last couple of days. They've had, I think, the HHS director, CMS director, rather, I should say, Seema Verma, who's from Indiana, just recently put out a letter talking about physician bureaucracy and trying to reduce that for providers, and that there's a lot of burnout with doctors and nurses, and saying we trained you all to lay eyes on people and take care of people and provide diagnosis and treatment. We don't want you to spend your time being data entry folks. And they're going to start trying looking at interoperability of EMR systems or electronic medical record systems, because we have different systems in different hospitals that don't talk to each other. They can't share information. The problem with electronic medical records is kind of like, again, I keep using bank analogies, but like an ATM machine. You'd be able to go to any ATM machine in the world with your card, be able to punch it in and get your credit balance and how much you got. You can withdraw, here's your fee, and you know exactly what you have in your account. They want to do the same thing with healthcare. The problem with healthcare is it's not quite as simple as a few numbers. You're having to put lots of data, social history, family history, medications you're currently on, allergies, all that information. It might be different from different providers to make sure it's all in the same consensus. So if you have a portal where patients can go in, double check their information, make sure it's accurate, and have computers from different hospitals talk to each other to share a lot of that information. That's been a struggle to this point, and part of the frustration. The federal government says they're going to start working on trying to get that, to de-burden our providers, to let them be more driven towards patient care and away from that. And I think they just put out also, I think it was yesterday, put out another notification looking at a lot of our regulatory statutes, things like anti-kickback statutes for docs. There's a lot of federal guidelines. For example, as a provider, I can't go to another doctor and say, how much do you charge for a level 3 visit for blood pressure? If they tell me that information, now we're fixing prices, and it's an antitrust violation for providers, and you could get a felony charge from the federal government. So those kinds of rules and anti-kickback rules, a lot of small things that are, again, burdensome. They're looking at reforming some of those statutes, looking at HIPAA. For example, you often see doctors have a sign-in sheet at their desk when you come in to see them. They know who's in the lobby waiting. They can't leave that list exposed for others to see, because someone might walk in and know that a certain person is waiting for a visit. That's considered a privacy issue. They're looking at reforming some of those things, I think, on the federal level as well, which is encouraging. So I think the feds are starting to see some of that problem. I know I've been part of a group that had a chance to go up and talk to the White House and people up in HHS about a lot of these frustrations that we're experiencing. And I'm encouraged to hear that they're actually listening to us. With all that said, we've also got our own issues with Medicaid here. We've got about 1.4 million people, a little over that now. About, I think, a third of our population that currently is using Medicaid. With the expansion that occurred back in 2009, we've got about 400,000 people that have been part of that expansion, which has been good as far as getting people with screenings. The hard part becomes the costs that go associated with that. And so trying to get those costs reduced, I think our current governor had campaigned on reversing the entire process, and I think once he got in, realized there's a lot of benefits. How can I make this sustainable? And he's created his own kind of 1115 waiver, we call it, which is we are applying to the federal government for innovative solutions to help with Medicaid costs. And so I thought I'd cover a little bit about what that waiver is. It's currently on hold. We've had a federal judge who looked at it and was concerned about a very narrow ruling that the federal government may not have looked at one aspect of it, so it's been put on hold until they get clearance from the Department of Health and Human Services about that aspect as to whether or not it gets expanded. But it's based very similar to what Indiana had done in the past. And in Indiana, what they did with Medicaid was they thought, how can we incentivize people within our Medicaid system, which are poor, often have poor health scores? How do we incentivize them to get healthier? How do we incentivize them to want to take responsibility for their own health issues, get their prenatal visits done, go see the doctor once a year, get their cancer screenings, etc. What Indiana had done a few years ago was they decided we're going to create a kind of a private insurance model for them. So if any of you have private insurance, you know that you have incentives to go get your colonoscopy done or mammograms or to see your doctor annually, if you're exercising, if you're losing weight. They put money off into health savings accounts and that sort of thing. And Indiana created a health savings account for their Medicaid recipients the government would fund. And they said, these are the monies you're going to use for your co-pays, for ER visits, for your doctor visits, for any kind of pharmaceutical co-pays, all that sort of thing. And then they said, if you do good things, you lose weight, you quit smoking, you get your diabetes under control, you go see your doctor once a year, all those screening things, we'll put money into those accounts for you. We're going to charge you a premium every year, and it's going to come out of that fund, and that's based on how much your income is. So it might be $1 a month, or it might be $100 a month. But if you do really, really well, then we'll lower that premium for you every year as well. And people thought, Medicaid recipients, they're not going to do all those things. They get their care for free. They're not going to care. And they had a bit of a punishment saying if you abuse this system and use all those funds, you don't do the right thing, we might suspend Medicaid for you for 3 months where you lose it. But if you do the right thing, we'll expand your dental, your vision coverage. We'll give you better pharmaceutical coverage. Make a long story short, in Indiana, they rolled it out, and they found that people did respond. And they saved about 7% of their Medicaid budget, about $500 million annually. They took those funds, went to their doctors and hospitals and said, we're going to pay you Medicare rates for Medicaid services, which is about a 20% increase. And a lot of those providers who wouldn't take Medicaid before said, if you're going to pay me Medicare rates, I'll take on more Medicaid people. So the access improved for them as well. And everybody started looking at Indiana's model, and they went ahead and expanded Medicaid based on that model. So we did it backwards. We expanded Medicaid without really having a means of how to pay for it. Right now, without anything, we're facing, I think for next year, the Medicaid deficit is going to be about $260 million that we don't have that we could come up with for Medicaid. The governor's solution was using Indiana's model, and to make it innovative, he added a work requirement to say that if you're an able-bodied adult that doesn't have any dependents, but you can work and you're getting Medicaid benefits, you get 3 months. After that 3 months, you either have to get into school, to get an education, to get a job, go learn a trade so you can go get a job, or go volunteer in your community for 20 hours a week. If you don't do those things, we're going to drop you from the Medicaid rolls. There's about 200,000 people that currently fit that category that don't have dependents that are able-bodied adults in our state. It was, like I said, it was going to get ready to roll out. It was supposed to roll out at the first of the month up in Boone County and then gradually expand to the rest of the state. And that's really been on hold, and how long it'll be on hold, we're not sure. It might be a matter of a couple of months. It may be a year. Depends on how quickly the federal government can work with that in terms of getting it accelerated. But we're hoping that that will help at least push a lot of folks that we have a lot of job needs. I'm sure there's a lot of employers in this room today. The issues that you have with trying to find people that are qualified, that are drug-free, that can come out and go to work and show up. We're trying to incentivize a lot of these folks to switch from the public insurance into a private insurance market and then be able to take some of those funds they have in those accounts with them. So when they make the transition, 50% of that money can follow that person in to fund their next account, so they can keep their healthcare rolling as well. So I think it's a good waiver. I think it's the only way we're going to see really a means of saving the Medicaid expansion. If it doesn't go through, we're going to have a hard time coming up with $260 million. And I think the amount, when it's fully implemented, when our share of it's 10% to the federal government, it's about $300 million a year. We'll struggle trying to find that funding. And so, at that point, I think the thing that might happen is we'll scrap the expansion, which I think won't be good, really, from a public health perspective. So we're trying to find a means of being able to keep that afloat and keep that alive. So that waiver is out there. That's kind of a current change within Medicaid. I've got my own ideas. I think some of our health department folks are here today. They've heard my concepts of using our health departments as a means of managing Medicaid for the future. And really, our insurance companies have struggled in terms of finding payments. There's been a lot of issues and concerns in the past. They're starting to turn the corner on some of those things at this point, but there's still a lot of that proof is still in the pudding as far as getting a lot of those things out there. I also brought a list of some of the bills that we've got done this past year in terms of healthcare issues. I brought my list. Since Jared kind of comments on it, but I've got about 19 of the bills that I filed through, and a lot of them are healthcare related. I mean, in terms of fair contracting, an appeals process for managed care organizations, pharmaceutical bills, colon cancer prevention, the review panel bill we talked about. The review panel bill we're really hoping is going to help reform a lot of the issues of liability, which is always a big focus for me. Some of the bills that we didn't get through, one was Senate Bill 2, which was an amendment to the Constitution that would have given the General Assembly the authority to set caps on non-economic damages when it comes to civil liability cases. So that if you sue somebody, in a medical suit, for example, malpractice, you might sue a facility for, A, B, and C, and let's say you win, you have a mathematical formula that determines your lost wages, your medical costs, all that sort of thing. The wild cards are things like pain and suffering or punitive damages, which can obviously be very, very high amounts in the state. And when one case goes really, really high, it affects all the insurance rates for the rest of the state. So to put a bit of a cap, it allowed the General Assembly to set that cap, and voters can vote people in based on their policy positions on that. We had a hard time getting that through the Senate. We're hoping to bring it back again in future years. But again, I think we rank 42nd right now overall in liability climate in the country overall, from a business perspective, not just from healthcare-related issues. We also had a bill that proposed some changes into to lawsuits, effectively in terms of allowing doctors to say that they're sorry, a physician apology bill, that if someone expresses condolences in a case, that won't be used against them in a court of law. But they've implemented that in our VA medical system in other states. They found major drops in lawsuits because sometimes I think families just want to know what happened, what was the issue, what was the case. Our providers are scared to give any information sometimes for fear of liability, and so it just becomes things that are hidden. And so to allow that conversation to occur, trying to put that in a statute. Also, contingency fee caps on attorneys who do sue in those cases to say here's how much you can make for the first $100,000 and mimic what other states have done in that as well. All of that is about the Supreme Court. They've invited me to be part of a commission to talk about reforming our civil liability system. They understand the need for those reforms as well. And we're trying to get some of those things changed when it comes to that. Other bills we try to get through, smoke-free schools, is something I've been working on. It's interesting on the smoke-free topic or tobacco use in our state. It's a state that's built a lot of its wealth off of tobacco. A lot of farmers who are very endeared saying it's put food on my table. It's paid for our family's sustenance for years. And so you still have that dynamic, I think, within the General Assembly. But there's a lot of it's bipartisan, and I think it's more of an urban-rural fight about trying to create an environment that's smoke-free. So that if you want to do something that's potentially harmful to yourself, that what you're breathing out is not affecting others around you, particularly in our schools and in workplace settings. I've been a big proponent of those things. I filed bills for those things. We've got that through the Senate, the smoke-free schools. The House hasn't taken that up in years past, but we'll keep filing a lot of those bills. 3 big bills we talked about trying to get more transparency. There's one called prior authorization bill. If any of you have ever had a medicine that you were on, that your doctor had you on, and your insurance company said they're going to switch it to something different, they give whatever reason they want to give, and you switch, only to have a year or 2 later your doctor come back and say, I got to switch you back to the first drug because now the insurance company's got a new contract for the first drug. There's all kinds of prior authorization headaches for providers in hospitals to get surgeries and that sort of stuff done. This would have been a bill that would have expedited that process for patients and for our providers. Healthcare transparency, to lay out kind of, right now a lot of our hospitals, for example, if you have, say you get in a car wreck and you have a bad back or a backache and you want to get an MRI. That MRI through your auto insurance might cost $3,000. Through your private insurance, health insurance might cost $1,200. If you're self-pay, it might be $500. So what's the cost of the MRI? It depends on what insurance you have and how you're going to pay for it. We want to be able to put some transparency out there so hospitals can post, here's what it costs to do these procedures that they're most commonly done, that providers can do the same thing, that insurance companies can do the same thing, so that people will know and they can shop for their health care and be able to figure out what their costs are going to be. And then also surprise billing, which is another bill that we've been trying to file and get through. Sometimes you go and get a surgery done, you get an in-rate hospital, surgeons, whatever, you have a radiologist out of network, and you get stuck paying that bill because the insurance company won't. You want to get patients out of the middle of those fights. Lots of bills, things like midwife bill, which is always a big fight for us as well. We have a lot of people who want to do deliveries at home and want to do low-risk deliveries, and I understand the desire for that. There's also a fight about whether or not they should allow higher-risk deliveries. Should you be allowed to deliver twins or vaginal birth after C-section, or things that we know are higher risk, that leads to a higher risk of death either to mom, baby, or both. We've had a lot of discussions on that this past session. So always a lot of healthcare-related bills, a lot of opioid disposal. We have a new bill that came out, and if you go to the pharmacy and get a narcotic or a controlled prescription, they'll give you a powder that you can mix in, shake up to dispose of your narcotics appropriately in a controlled setting. I can go on, like I said, for an hour, and I can bore everybody to death with a lot of information. I'd like to open it up with many questions in particular, because I can read you a bunch of bills. There's lots of things we get done every year. It's complicated when it comes to healthcare, and a lot of things we're trying to get accomplished. But wasn't sure if anybody had any questions, any things you've heard about, curiosities. Kind of pretty much an open book on anything healthcare related. Yes.
On the opioid crisis, and we know that part of the blame lies with pharmaceutical companies that promoted opioids, and is that blood been stopped, or are they still pushing opioids?
Yeah, so from a provider perspective, I did run those numbers this past year. I just in terms of discussions on other bills, we've got mid-level providers who are trying to become independent with prescribing narcotics, both physician assistants and nurse practitioners. And so the concern becomes, okay, do we have enough prescriptions out? We ran some numbers last year to take a look at. We put a bill called the pill mill bill a few years ago. Remember that? To see did it work. We've seen dentists reduce their opiates down by 30%, physicians down 25%. As an overall state, we're down 10% from 6 years ago in terms of prescriptions being done. There was a recent study that came out that showed data that actually you're less likely to get a prescription of a narcotic from a doctor when you go to see them anymore. I, for one, the regulations that were put in, I don't write outpatient narcotics or controlled substances anymore because I have to follow all kinds of guidelines to be within the law, and so it makes it really difficult to do. So I think you're seeing doctors do that. A lot of discussions, even the University of Kentucky Trauma Center, I've talked to their trauma surgeons. If you go in and get a bunch of broken bones from a car wreck, you would think you'd be loaded up with narcotics or pain control. They're using IV Tylenol and ibuprofen after these kind of surgery, and people do okay. So it's just changing the mentality where in the 90s, the pharmaceutical companies did come in and say, hey, keep people's pain under control. It's the sixth vital sign. If you go to a doctor's office, do a little frowny face and smiley face, where's your pain level? They want to know, and if it's frowning, give them a narcotic. That's the strongest pain medicine that we have. You really need that for every case. And so I think doctors become a lot more judicious about where they're using these narcotics, even in hospital settings. There's clearly cases where you need it. Obviously, people that go through hospice or cancer or something like that, very painful conditions, we want to keep those folks comfortable. But you don't always need that narcotic, and that's, it's funny when I got people come into the nursing home, 90 years old, had a broken hip, and they're on huge doses of narcotics from the hospital, and they can't get up to do their therapy. I wonder why. They're on tons of narcs, so you have to quickly wean them off and try to get people more functional. I think you're seeing the medical professions responding to that. But again, the opiate problem right now, what we're seeing is a decrease in heroin and an increase in methamphetamines. That's back on the rise. So it's, again, if you're an addict, it's truly a medical condition, and a lot of these folks will just seek out the drug that gives them their high, their buzz. It's providing, I think, better access for treatment. How are we going to fix a lot of those issues? We've got a new $30+ million grant that's coming from the federal government to help us do that. And I think the focus from the Senate, at least from our perspective, has been more about punishing. We really want to punish and hammer the people that deal these drugs and put them away. And we don't want them around. We've created new felonies. If you're bringing it in across state lines, you're looking at another 5 to 10 years on top of what you've already got from an importation felony. The people that really are seeking treatment or need that help and you can reach, you want to be able to provide them resources to get them off of this stuff. So I think it's become a renewed focus. I think the medical profession is responding. The data suggests that. It's just that there's so many other drugs that are floating around out there. They come from Chicago and Dayton that people get their hands on. And I had a 26-year-old young lady the other day that admitted with cellulitis. She had track marks everywhere. A young, broken lady who I think you can reach and probably help out. But didn't even know what she was shooting up in her system. When you look at her drug screen, she had PCP in there and heroin and fentanyl, and she didn't know that she had that in her because she didn't know what she was putting into her system. So it's tragic, really, what happens to a lot of our young people. And again, we don't want to give them that. Sometimes just that one dose of, you don't think anything of it, you get a tooth pulled, take one pill, that's enough to hook people, and they get stuck with that for the rest of their lives. So I think we're doing a better job of trying to use, kind of what we consider milder drugs that have worked for millions of people around the world for a long time. I got some health department folks. Yes, yes.
Yeah, coattailing on the same thing. I know Kentucky does have a huge opioid crisis, and I see it in my office every day. I know in West Virginia they passed a bill or a law a while back that said that before opioids are prescribed, you need to go to a therapist or a chiropractor to try and do preventative maintenance or preventative healthcare first. Has that come across your desk, or is there any plan for that?
It hasn't. The hard part with putting, when the pill mill bill first came out, I'll give you an example like that. I didn't like that bill as a provider. And even though it's worked, it's reduced the numbers down to some degree, it also told a guy like me who was responsible with it. I run Casper's, and I was, pretty tight to prescribing any kind of narcotic. When you start telling providers how to practice, you've got to do A, B, and C. Everybody gets upset, and legislators don't like to tell individual people how to do things and you don't want to tell a doctor how to practice medicine. So that's the glitch with that. I mean, in terms of trying to say, hey, you're going to do it, we're going to tell you how to practice. That doctors don't like it, nurse practitioners don't like that, PAs don't like it. That's the hard part with that, is to try to start determining those things. The fact that they just telling doctors you got to run a Casper, you got to ask all these questions, put this in the record was enough for me to say, if you're a child with ADD, there's no psychiatrist to see you. I was your psychiatrist effectively. I had you controlled. You went from an F student to an A student. You're doing great in school. Everything's wonderful. I had to tell those people in April, I won't be writing your medicines come July, because it's a bill that was passed just before I got in office. And I said, because I got to do a 114-point checklist, I got to document all these things every 3 months in my record. It's going to take me 2 hours to do that. I don't have the time in my office. I'll go bankrupt. I can't do it. So we just said, go find a psychiatrist and good luck. And I told my school system, you might get a lot of kids dropping off these medicines. So a lot of that stuff came out. Changes were made to that law to make it easier for nursing homes and for hospitals. But when you start dictating a lot of that, that becomes a concern with a lot of it. Now, I think to your point, I think it's probably a wise choice to say, hey, before we consider a narcotic, go explore every potential option you've got. Go see chiropractors, go see physical therapists. There's massage therapy opportunity to have people that respond well to that. That often isn't funded. And to try to keep people from getting onto that narcotic. And I'm sure the cost savings for that would be huge. So the worries are always, we pay that money up front with potential back savings. In medicine, it's very hard to convince my colleagues, especially on the Appropriations and Revenue Committee, hey, if you just spend a little bit here, we're going to save all this money on the back end, because they've heard that with so many other projects. And they think, I've heard that before. I don't know if that's really going to happen. I know that I believe you. And so we've got to either try pilot programs to get those things done, where we say, hey, a couple of communities are going to try that, and here's how much money we saved. Let's do the same thing for the whole state. That's where we're going to start seeing more of that success. So if we're going to try programs like that, we've got to try, I think, get a couple of communities, pilot it, make Medicaid pay for it, or do something, and then see the outcomes. And I think we'll probably see a lot of savings. But I think a lot more providers starting to channel people into, kind of non-prescriptive methods of pain control, which is what we need. I got some help coming out. Health department people are going to ask me something, surely. I got you guys in the room. And I think well, like I said, thank you all for having me. I said we try to provide, I can go through a whole list of bills of things we're trying to get accomplished. Those are some of the problems that we're facing, I think, as a society, and I think as a state. A lot of what you're seeing come out is to help channel a lot of those things in a better fashion. One bill that I'll mention before I sit down is direct primary care. It's kind of a new model. You talk about legislating something. We're not telling people how to practice, but we're recognizing that direct primary care is not an insurance policy. It's a method of providing health care. A lot of our doctors now are doing what I call blue collar concierge medicine. Instead of paying $2,000 a year to have your doctor at your beck and call, they're charging people a monthly subscription of like $50. It's not an all-inclusive fee, but they'll handle all your primary care needs. These docs don't deal with insurance. I've got Medicaid folks that are on Medicaid that are working, that will pay their doc $50 a month. They'll see them whenever they need to. They'll handle all their issues and problems. They use their Medicaid as a catastrophic insurance policy. Those doctors have less patients, they probably make less money, but they're happy again, and they're not having to do electronic medical records. They can take care of their patients, see them when they need to, provide that care. I'm trying to see if we can drive that type of model within Medicaid. And I've got some concepts on using our health departments as a means of the tool where money can flow into the health department for Medicaid. They can then go out and contract with hospitals in that method, with doctors in that method, and say, you know, I'm going to pay you X amount of dollars. You handle all of the issues for all of our patients when they come in your front door. And so if the hospitals have their money up front and they know what they've got, then they're interested in keeping people out of the hospital and keeping them in an outpatient setting, out of the ER if you can. Same thing with private physicians, is to say, be at their beck and call. We're not going to oversee your notes. We're going to trust you to do the right thing and get back to that kind of style of medicine. I think if we do that as a society and as a state, we'll save a lot of money. Patients have more responsive physicians who will be happier, frankly, and probably can see more patients. So we're trying to look at some of those kind of models out of the box to try to drive things with healthcare and Medicaid moving forward. There's no other questions. Thank you all very much for having me. I appreciate the invitation, and have a great week. Appreciate it. Thank you.